Well, thank you, Dr. Coulter and Dr. Rogers, for inviting me and putting this together. And little fun fact about Dr. Rogers, I've known him for 35 years, and I met him when he was an intern at University of Nebraska, so we go way back. And I would say I've been truly blessed with my career and a lot of good fortune, but working with Joe and his team here at THI, being part of this program really truly is a highlight, and I'm so happy to be here. The other thing, as a disclosure, I have not seen anybody's talk or their slides. And I would think maybe they saw my slides because they look very similar. But the take home would be, there is a very purposeful theme here that we are all thinking. We may be in silos, but we are all thinking about the same thing. And as we have all talked, this is a very meaningful program. And if we do not get forward momentum and forward progress, it is on us that we failed. We have to make this stick, and we have to really make something out of all of this. And so this is my topic. We have the tools. It's time to unite. And one little thing here, this is a health crisis. Do not fool yourself. And I am going to be very frank. The New Yorker in me is going to come out, but this is a health crisis like we have not seen. Now, a few years ago, I was invited to speak at a large hotel in Las Vegas, and a large crowd. It was a raucous crowd. I was the keynote speaker, and they were playing music, and they had lights flashing, and I panicked for a minute. And in the 30 seconds before I walked out, I said, I need to come up with some sort of catchphrase to meet the excitement of this whole meeting. So I grab a piece of paper, I find a Sharpie marker, and with whatever inspiration I had, I wrote this down on this piece of paper. And the key theme for now, and also for the day, we have to make visible what is invisible. I'll say it again. We have to make visible what is invisible. And what I mean by that is the walls are caving in around us with metabolic syndrome and obesity and liver disease and cancer. But you know what? If you could see, if you have one eyeball, it's all over. It is in front of us. We don't need an electron microscope to see this. We don't need some fancy DNA probe. We just look around and you will see we are surrounded. The ship is sinking and people are dying, and we have to do something. Now, this is a patient of mine who yesterday we caught her TikTok video. She gave me permission to play this. This TikTok video has over 1 million views. This thing went viral. And I'm going to play it for you.
Can we talk about the amount of people that have fatty liver? A lot of you have been told what I was told, which was, we'll see you back next year, we'll keep an eye on it. And the we'll see you next year, we'll keep an eye on it happened for 5 consecutive years, and I ended up with stage 3 liver disease. When I found out, I didn't do anything about it because I trusted what my doctor told me, and that was the biggest mistake that I did. I was in the same spot that most of you are right now. And I got confirmation that all these doctors are still telling us the exact same thing. You have fatty liver, a lot of people have it. Don't worry about it. Just, try to eat better, lose weight if you can. That it's okay, it's fine. I'll see you next year. It's not fine. It's not okay.
Okay? Make visible what is invisible. Now, I tend to have a very simple approach to all this. This is a humongous, complicated problem. But let me just say this. If there was no obesity, there would be no metabolic syndrome. There would be no cardiometabolic syndrome. There would be no fatty liver. there would be no diabetes, cardiovascular disease, and cancer, and there'd be reduced death. And so keep that in mind. Very simple, but it's the truth. Because having your liver end up in a bucket at the time of transplant is a failure of decades of potential intervention. And you know what? Shame on us. Shame on us. So I'm here to talk about fatty liver. Now, fatty liver over several decades has gone through a morphing of the name. And it all started back in 1980 at the Mayo Clinic. Dr. Ludwig, who's an esteemed liver pathologist, made the observation, hey, there's a lot of people that I'm looking at liver biopsies, and they have fat in the liver. And the dogma was chronic alcohol abuse equaled fatty liver. And so when we would see somebody with a fatty liver, we said, hey, you're an alcoholic. You're an alcohol abuser. You have alcohol use disorder. But Dr. Ludwig said, well, wait a second. These people are not drinking, but yet there is fatty liver. And it started this chain reaction of thinking. And it wasn't really till 2002 that the MASLD, which is American Association for the Study of Liver Diseases, our main organization, came up with the first term NAFLD, non-alcoholic fatty liver disease. Then by 2020, we tried to refine it a little better, and it became metabolic associated fatty liver disease. So we're starting to get the idea that there is a problem of metabolism, metabolic syndrome. And finally, this year, the new official name is MASLD, metabolic dysfunction associated steatotic liver disease. We got rid of the word fat. That turned a lot of people off. Or MASH instead of NASH, which is metabolic associated steatohepatitis. Now, when you hear the word hepatitis, that strictly means inflammation of the liver. And as others have said, inflammation is the driver of tissue damage, whether it's in your brain or in your coronaries or in your joints. Inflammation is bad. So we're MASLD and MASH. So by definition, you have to have greater than 5% fat in your liver, but the absence of other causes of fat in the liver, other liver diseases. Little or no alcohol. So you have to take a good alcohol history. Do not simply write down social drinker. Okay, I'm a social drinker and I'll have maybe 3 glasses of wine a month. Somebody else is a social drinker and they have 2 glasses a day. They're not an alcoholic. They don't have alcohol use disorder, but that's a lot of alcohol. Okay, even more if it's a woman. Now, the key thing here is that there is this somewhat predictable transition from simple fat in the liver to inflammation, ultimately leading to cirrhosis, which is scarring of the liver. And I would say for the cardiologists here, you probably see the same thing in the heart, in the coronaries. A little bit of plaque, a little bit of irritation, inflammation. Ultimately, you get a big clot and everything stops flowing there. But the other thing is, with this progression from steatosis to inflammation to a little fibrosis, a lot of fibrosis, and cirrhosis, the end stage is liver cancer, hepatocellular carcinoma. And that is a real horror for us. Now, when you look at the whole scheme of steatotic liver disease, we can't call it fatty anymore, steatotic liver disease, the real part of this sort of table here is on the left side, where you've got this metabolic dysfunction associated steatotic liver disease, MASLD, and or the MASH part. Now, MASH is the more aggressive form where there's inflammation, and that is what leads to the fibrosis. Now, in the middle there, we talk about alcohol. We know that alcohol is a tremendous driver for fibrosis. So again, there is this in-between state of what's called MetALD. So they have metabolic syndrome with the influence of alcohol. So again, you want to take a detailed alcohol history, and we would do it by number of standard alcoholic drinks, be it a can of beer, be it 5 ounces of wine, be it a shot, 1.5 ounces of spirit, which all contain about 10 grams of alcohol. So you would record it by how many grams of alcohol per day or per week. Now, the interesting part, and this is, we were talking about guidelines before, American Heart Guidelines. Well, in liver disease, we have caught on and we have guidelines of our own. And this is directly out of one of the hepatology guidelines where for the first time, they actually include in a liver guideline cardiometabolic criteria. I saw this and I said, wow, we are part of the modern time here. So again, if you start off with steatotic liver disease and they ask the question, does the patient meet any cardiometabolic criteria? You follow the algorithm. If it says yes, then you say, are there any other causes of steatosis? If the answer is no, then you arrive at that MASLD position. That you could say that they have that. And then, of course, there's some other indications, weight loss and medications, which we're really not interested in right now. So there is a pathway for us as hepatologists to incorporate metabolic syndrome, cardiometabolic criteria to see if that's where our patient fits in. Now, these are the criteria. Now, all you need is one of these criteria to be considered at risk for steatotic liver disease and, of course, the potential for cirrhosis. And this is all pretty straightforward. BMI greater than 25 or a waist circumference increased, fasting glucose. And again, everybody here so far, we've talked about all these risk factors. Blood pressure, hypertension, again, 130 over 85, or if they're on medicine for it, okay? Plasma triglycerides, Dr. Ballantyne, we're including you here, and plasma HDL elevation, or if you're on a lipid. So the guideline says if you have one of these, you need to be screened for fatty liver disease. End of story. That is the guideline. Is it being done? No. So the comorbid conditions with steatotic liver disease, it is an instant replay of what's been said. Obesity, right? So if you're obese and have fatty liver, you have insulin resistance, you have increased risk of cardiovascular disease, liver fibrosis, regardless of your BMI. So there is this sort of thin fatty liver that they're at risk for advanced disease. Type 2 diabetes. All patients with MASLD need to be screened for type 2 diabetes, typically with a 2-hour glucose tolerance test. Is that being done? No, it's invisible. People don't see it. You walk in with a blood glucose of 105, A1C is a little elevated. You know what? You just have a touch of cholesterol. You have a touch of hypertension. Don't worry about it. I'll see you next year. This is exactly what the patient said. Hypertension associated with hepatic fibrosis, dyslipidemia. Statins are safe. They're just not being used. They're just not being used, because I watch late night TV and there is a disclaimer. If you've got liver disease, talk to your doctor. It might be bad for you. So patients come in. I'm not getting on a statin. I got elevated liver chemistries. What I tell them is you probably need to double your statin, okay? Obstructive sleep apnea, cardiovascular disease. Number one killer of patients with fatty liver disease, cardiovascular disease. They're dying of heart attack and stroke. And then, of course, chronic kidney disease. So I think when we started talking about it, and it was sort of new to me, this cardio kidney, I think we need to add cardio, kidney, hepatic, oncologic syndrome. That's really what it is. So this is a tsunami. And like all tsunamis, they're silent and deadly. So here's our fatty liver. 80 to 100 million Americans, globally 30% of the population has fatty liver. Leading cause of cirrhosis, leading indication for liver transplant, and also liver cancer. And we were talking about the cost of cardiovascular disease. Well, I'll jump on that billion-dollar wagon. It's cost about $100 million for fatty liver disease. Now, the challenge here, imagine if we could shave off 1/100th of this cost. And I give Dr. Rogers $1 billion. Well, he could buy a lot of bicycles for our obese patients to ride their bike and they could exercise. We could buy a hell of a lot of broccoli. We could buy pots and pans and a good chef's knife to have people cook their meal at home, okay? Maybe even a microwave. I don't know. How about a blood pressure cuff for everybody, Dr. Ballantyne, right? Home blood pressure. Every family gets one $20 Omron blood pressure cuff just by shaving 1/100th of our healthcare costs. Now, again, this whole invisible thing that I talked about, what we don't see with obesity. Now, I see the tip of the iceberg is fatty liver. But we see cirrhosis and depression, cancer, erectile dysfunction, lower survival, stroke, right? This is not new to any of you. But it's really interesting. When they asked patients that had fatty liver, only 5.1% realized they had a liver disease. So whose fault is that? Theirs or the doctor's? I think it's the healthcare system. Now, if you ask patients with Hep C, 42% know they have a liver disease. They have Hep C. Less than 20% of all cases of fatty liver disease are diagnosed, and greater than 50% of PCPs are unaware of the fibrosis risk and their cardiovascular risk. So fatty liver disease, to me, underdiagnosed and undertreated. Now, the question is, what other disease gets this kind of treatment? So this is a mammogram. And I took the liberty of putting a red spot on it, right? You go for a mammogram and you get the report, hey, there was a spot on my mammogram. Well, there is absolute intolerance to inaction of this mammogram. Can you imagine if your loved one goes for a mammogram and they say, well, there's a spot on your breast. Oh man, you got to see a surgeon. You need an MRI. We got to do something. Where's the surgeon? Biopsy it. Yeah, no, we're going to watch it. Okay? That would never work. The doctor's office would be picketed the next day. But fatty liver, hey, we're going to watch it. Come back next year, and next year, and next year, and next year, and next year, until they see me, and they got a big tumor in their liver, and I say, we really can't do anything. You look at the old records, 10 years worth of elevated liver chemistries in fatty liver. Now, Peter Attia, who knows Peter Attia? Or knows of him, okay? So he wrote a book last year or so, Outlive. And he's big on social media. He's, a lot of people love him. I like him. The one thing he talks in his book is this thing about medicine 2.0 and medicine 3.0. Medicine 2.0 is where we're at today. We treat a blood sugar when it gets to a certain level. We treat hypertension when it gets to a certain level, when somebody is symptomatic. What he talks about is medicine 3.0, which is what we're talking about. It is prevention, right? So you know that somebody, because of their genealogy or whatever, is going to be at risk for heart disease or cancer. You don't wait until there's a tumor. You don't wait till they have their first MI or their first episode of AFib, you have to start treating decades earlier. And I would say this is what he is putting forward, and I would agree. So in your typical liver clinic, the phenotype patient that I see is obese, they're hypertensive, they have insulin resistance, they got elevated liver tests and a fatty liver. We're going to address well, I wouldn't say this is not my clinic, other nondescript clinics out there. They'll evaluate the elevated liver chemistries and the fatty liver, but all that other stuff is ignored. But then the same phenotypic patient walks into a cardiology clinic. They have hypertension and hyperlipidemia, but they're obese, they're insulin resistant, they have elevated liver chemistries and a fatty liver. Oh, well, look, we'll treat your hypertension and we'll put you on a statin and recommend, you walk around the block. But this is what I see. We're going to defer to nephrology, defer to endocrine, defer to your PCP. Bob the plumber, we'll defer to him too. But the truth is, we'll defer to anybody but me. Okay? We're just gonna, this is too much. And things don't work out. So, all-cause mortality is increased in people with fatty liver disease. Increased non-hepatic malignancies. These people are sitting ducks for a bunch of cancer, in addition to liver cancer. Now, the progression from one stage to the other, from early fibrosis to stage 2 fibrosis, stage 3 to cirrhosis, if you have MASH, the more aggressive form, it's about one stage every 7 years. If you have MASLD, it's a little less, it's about one stage every 14 years. But the wild card here is alcohol. You throw alcohol on this, you have a smoldering little fire that turns into a forest fire. And so we see patients that have, intermediate stage disease, but they're still drinking. Nobody told them to stop. And they show up with cirrhosis 5 years later. And these are the malignancies associated with obesity and being overweight. Breast cancer, we see a number of women that are coming in with breast cancer. No risk factors. They have breast cancer at 35 years old. Why? They've had metabolic syndrome for 20 years. So keep that in mind too. Now, the picture is not too rosy here. From 2015 to 2030, and again, there were similar curves in the heart data. All of this is going up. And if you look at the bottom right on the MASH, the more aggressive, by 2030, there's going to be more cirrhosis compared to what we see now. So again, we're going in the wrong direction. Speaking of the wrong direction, I have 2024 dotted there, but liver-related deaths, hepatocellular carcinoma, and decompensated liver disease is all going up. And if you look at transplant registry, these are the diseases that patients are being listed for transplant. And you can see here that for the male on the left, besides alcohol, fatty liver disease is increasing, but for women, it is the #1 indicator for liver transplant. So again, I get a little sick and tired of all the lip service. We worry about the women's health. It's important. Well, somebody is asleep at the wheel if this is happening. With all that we know, we're happy with this? This is horrible. Now, it's all about screening. So that person that ends up needing a liver transplant, to me, as I said earlier, it's a failure of decades of potential intervention. We now have something called a FIB4. It's a blood test. There's an app for it you should all have. You plug in a few lab numbers, their age, and it tells you the likelihood of them having advanced fibrosis in their liver. We also have something called a FibroScan. It takes about 3 minutes to do. It's cheap, and we can detect fibrosis in the liver to see if they are on a trajectory for more advanced disease. Now, we're transplanting patients with fatty liver left and right, but they get recurrent disease in the new liver. And then what do? We don't change behavior. They never learned how to eat. They never learned how to cook. They never learned how to shop. Now, I was thinking this over. Nobody likes car accidents, but I looked at the automobile fatalities over the years, okay? And this is what it looks like. Now, don't get fooled by the green line. The green line is indeed the number of deaths, and that's sort of wonky. It really hasn't changed. But if you look at the rates of death per number of motor vehicles or the number of miles driven, this is a very nice example of putting into play sequential safety measures in your automobile. And so every few years, they put seat belts, they put brake lights on, dual airbags, tire pressure monitoring. So why can't we, in healthcare, institute a series of proactive interventions to model this so that mortality goes down nice and smooth like we see with automobile fatalities? And so clearly we're going the wrong way. So the connection with heart disease and MASLD, you've heard this before, they have worse coronary calcium scores, increased carotid disease. Now these are people with fatty liver, but really the secret is they've got metabolic syndrome. Okay? It's metabolic syndrome dressed in a different outfit. Imbalance in coagulation, they're clotting. Cardiac function, they have LV diastolic dysfunction, more AFib and AV block. Abnormal cardiac energy metabolism, similar to children with fatty liver disease. Maybe Dr. Harpavat will talk about that. And in 30,000 people with fatty liver disease, fatal and non-fatal events were higher. MI, CVA, angina, 64% higher in the fatty liver group. The most interesting thing here is the microbiome. So that is the trillion bacteria that live in your gut. And with junk food, high saturated fats, sucrose, high glycemic index foods, processed meats, the shape of the microbiota is less favorable in the fatty liver patient. And there is this specific profile that you see with the fatty liver patient. It causes inflammation, more coronary artery disease, ischemic stroke, vascular calcifications, etc. Bad news. But this really is a Texas problem. Similar to the heat maps that have been shown, liver disease mortality is really not good, really high in Texas and other pockets around the country. But when you look at Hispanics here in Texas, there's something unique about the Mexican Hispanic versus the Cuban or Puerto Rican or Dominican. The Mexican ethnicity poses its own increased risk to fatty liver disease. Now, looking at liver cancer, the hot zone in the country is in South Texas. And you can see down in the Rio Grande Valley and out in West Texas. Liver cancer mortality, same thing in those areas. Now, if you look at liver cancer incidence in the entire country, Texas has the highest incidence of liver cancer per 100,000 population. And the latest number for 2024 is that there will be over 4,000 cases, up from 3,000 cases when the data was reported in 2015. So right in our own backyard, we have a lot of badness here. And when you look again at all liver cancer incidents across the Hispanic spectrum, it's the Texas Hispanic compared to the Floridian Hispanic, okay? There's something unique about Texas here. Now, whether it is food, environmental, the soil, the air, I'm not quite sure, but people are looking at this. And again, when you look at overall cancer mortality by sex, you have a male Texan versus a male anywhere in the United States. Texas wins, as well as with female. Females from Texas with liver cancer are dying at a higher rate. But the interesting thing, and this is out of the American Cancer Society statistics, at the time of diagnosis of liver cancer, 20% is already distant. It's already distant, so it's late diagnosis. That's what I would say. But lastly is my time, and the red light's going off. I don't know if a hook is going to come out. Let's talk about the food real fast. It's all about the food. And I did write a book, Eating Yourself Sick. A lot of people gave me a little heat about the title of it, but it is the truth. We are eating ourselves sick. And when you look at 1970 compared to 2020, there are more products in a grocery store now, and it makes us confused. Over 50,000 different unique products. And calories are going up, portion size, exercise is going down, and we're eating out more and not cooking at home. And a lot of people cannot pick out right food. They don't know how to meal prep. They don't know how to shop. They don't know what an asparagus is compared to a piece of zucchini. And my belief is that food, cooking, and nutrition literacy is down. And this is a funny cartoon from the New Yorker where this lady's just looking for a piece of fish, and the guy behind the counter says, you want wild caught, farm raised, lab grown, beach found, or aquarium harvested. And research has been done that the more options we have to purchase something, we get confused and unhappy. And this is what's happening with our diet. So, as others have said, we need to surround the fatty liver patient or that person with metabolic syndrome with hepatology, cardiology, endocrine, primary care, obesity, surgery, behavior, nutrition, and exercise to make this all work. Very simply, if you don't eat at home, you're going to shop outside for meals. If you shop outside for meals, you're going to get confused. You're going to buy processed foods. If you eat processed foods, you're going to become obese. You become obese, you get metabolic syndrome. So if we want to fight cardiometabolic, we have to eat at home. And I would say the emphasis here to close up, we need to bring back, I think, some form of home economics. We need to eat as a family. We have to get rid of junk food. We have to exercise, educate our providers, screen. Research is abundant. There's a ton of stuff we could do, and we have to stop kicking the can down the road. Thank you so much.